today to talk about Vermont's COVID-19 Therapeutics program. I work at the Department of Health in the Division for Emergency Preparedness, Response, and Injury Prevention, and specifically in the Healthcare Preparedness Program. And just a disclaimer, I'm not a pharmacist at all or a medical provider, and some of this can get pretty clinical, so I may have to just take note of your question and talk with our team of clinical advisors and get back to you if you have a specific clinical question. Also, just a note, I can't see the chat or raised hands when I'm in presenter mode, so I'll leave it to Anna and Rebecca to, feel free to interrupt throughout this with any questions you have. We should have enough time to ask questions throughout and then have some time at the end to discuss in detail and field your questions. So just a quick note before we jump into treatment is that treatment is really designed to prevent hospitalization and death from COVID-19, but we all know the best way to do that is by being up to date on vaccines. So treatment is not a replacement for being vaccinated. And with that, I will go ahead and get started. So COVID-19 therapeutics are distributed through the federal government right now. So the U.S. Department of Health and Human Services and what we call ASPR, the Assistant Secretary for Preparedness and Response, purchase drugs for the whole country and allocate them to states based on COVID data. And it's actually a bit of a complex algorithm. It's not just based on COVID cases in the state, it's based on hospitalizations and population density. And so based on that, every week we get a certain allotment of drugs. And what we do, our team, is we take that basket of drugs coming in from the federal government and we distribute them to hospitals and independent pharmacies in Vermont. The federal retail pharmacies, you might be more familiar with, like Walgreens or Kinney Drugs. They just recently have a separate channel for ordering and supplying therapeutics for their stores. And also just to note that many of these drugs are technically not approved yet. They are authorized under an emergency use authorization. And most are allocated on a weekly basis, except for one of them, which is allocated to us on a monthly basis. And how are they used? These are all considered, except for one of them, mostly an outpatient treatment that can be used to prevent or treat eligible non-hospitalized patients who have tested positive for COVID-19 and who have mild to moderate symptoms. And that mild to moderate symptoms is really important because when therapeutics are used appropriately, they're used early when people have detected COVID-19 and it hasn't become severe yet. So you'll hear me say this throughout the presentation, but the main message we want to send to the public is to, test early and treat early. And when we say treat early, really that means reaching out to your provider if you test positive for COVID-19 to talk about what treatment options are available for you. Prevention and early treatment for eligible patients can improve patient outcomes, reduce stress on the healthcare facilities, and ultimately save lives. This is probably the most text-heavy slide, so I apologize in advance, but we get a lot of questions about the difference between monoclonal antibodies versus antivirals, and both of these are in this suite of COVID-19 therapeutics. Monoclonal antibodies are human-made proteins that act like human antibodies. They're considered, you might hear them called like a biologic, and they help the immune system recognize and respond more effectively to the virus. Antivirals are a different class of drugs. They target specific parts of the virus to stop it from multiplying in the body. Both of them help prevent severe illness and death from COVID-19. What really separates them is the administration. So monoclonal antibodies right now are given to a patient through an infusion into a vein. So either through an injection, like a shot you would get, or through an IV, intravenously, over time through a bag that goes into a vein. And the antivirals, on the other hand, are just a pill that is taken by mouth, sometimes over several days. So what types of COVID-19 therapeutics are available right now? You can see I highlighted in red the monoclonal antibodies that we used to have. And basically, this just points out that, COVID-19 has thrown us a lot of curveballs, and as new variants emerge, it's possible that treatments, might not be effective against them. And that's what's happened with these three that are crossed out. They were really effective for the variants at the time, and then as new variants emerged, it showed that they were not effective, so they were pulled from from distribution. So the ones in green are the ones that are currently available to us, and they're all a little bit different. The Evusheld has a star next to it, and that's a different type of monoclonal antibody, where it's more of a preventative. So I'm going to go into detail into these in a minute, but Evusheld is a monoclonal antibody that is similar to a vaccine. It's for people who are severely immunocompromised and who can't take a vaccine for some reason. Maybe they're severely allergic to one of the ingredients. And that's the only therapeutic available that's for basically pre-exposure. So someone does not need to have COVID-19 in order to have Evusheld. And then we have bebtelovimab, and these words are really a mouthful. So if you're asking a question and just want to call it like Beb or Pax, that's totally fine. We do that. And then we have two oral antivirals, Paxlovid and molnupiravir, and one IV antiviral called remdesivir. And remdesivir is the only one listed that is actually not distributed by the state. And so it's not part of this program technically, but it is available. So this would be another situation where you'd want to ask your provider about this drug. And in fact, they would be the one to tell you if they recommend that over a different one. So when are therapeutics used? This kind of relates to what I was mentioning about Evusheld, but if we think about the trajectory of someone getting COVID-19 and what could happen, in the beginning, I'm just looking at these chevrons on the very first row here. Someone without any illness, and then they become exposed, they have mild to moderate symptoms, maybe they become hospitalized, and maybe they are admitted into the intensive care unit at a hospital. So where do these therapeutics come into play? At different stages. So as I mentioned, Evusheld is before the person actually has COVID-19, no illness. That's when Evusheld would be administered to someone who's severely immunocompromised. Once that person is exposed, there's no current drugs available. So this is exposed, but they're not showing any symptoms. And then say the person tests positive and they have pretty mild to moderate symptoms. Maybe they just have a sore throat or they're feeling pretty run down. This is really the time when most of our therapeutics work well. So this person might be eligible for Paxlovid or molnupiravir or bebtelovimab. And you don't really need to know the specifics about each drug. The main takeaway here is that when someone has mild to moderate symptoms, they reach out to their healthcare provider to talk about what treatments might be available. And then it's possible, that person gets hospitalized. There's only one drug right now that that person would be eligible for, and that's the remdesivir. So remdesivir can be administered when the person has mild to moderate symptoms, when they're hospitalized, and when they might be hospitalized into the ICU. A question we get fairly often are what are the testing requirements for therapeutics? And most of the drugs that are available require a positive COVID test, but it does not specify what kind. So you could use a regular rapid antigen test, or you could use a PCR test. Either of them are fine. You should just check with your healthcare provider about that positive test in terms of, can you just tell them over the phone, hey, I got a positive test. We heard that, some providers actually wanted to see the test just to verify it. So the best thing to do if you're wondering, what kind of, I guess, evidence of the positive test needs to be shared with a provider is to just give them a call. And it's important to note here that there could be costs associated with getting tested or the doctor's visit to get the prescription. But Social Security numbers, any type of proof of citizenship and insurance are not required, and the patients should not be charged a dispensing fee for any of these COVID-19 therapeutics. Basically, the federal government buys them and sends them to us, so they're a free resource for people. And as I just mentioned, it's free, so it's completely covered. There's no cost sharing. And you don't have to be a permanent citizen of the US. You don't need to share a social security number. Basically, you should just be able to go to your provider and say, I tested positive, and if you're eligible, they should be able to call in that prescription to a pharmacy, and you should be able to pick it up without paying anything. If you hear about someone who was charged, please let us know, because we are following up on those. The only exception here are drugs that do require a technical administration, such as an injection or an IV infusion. So for those monoclonal antibodies like bebtelovimab or Evusheld, there might be a cost associated with that doctor's visit or just the administration fee. So all of these therapeutics, as I mentioned, are authorized for an emergency use authorization during this public health emergency that we are in with COVID-19. And all of the language for these drugs states that they are for patients at high risk for progressing to severe COVID-19, including hospitalization or death. So what does that mean? Basically, you will see a link in all of these drug fact sheets that links to this CDC page called People with Certain Medical Conditions. So I just want to take a moment to explore that. It'll take you to this page here. And what's important to note here is that there is a bit more flexibility with therapeutics because they are authorized under an emergency use authorization. So don't assume that you might not be eligible because you don't have maybe a severe chronic disease. It's actually pretty broad, the guidance for giving treatment. So for example, if we scroll down to medical conditions, physical inactivity has been linked to more severe COVID-19. Being overweight has been linked. So if you have a mental health condition, so it's actually a pretty broad array of situations where you might be eligible for treatment. So the main message I just wanted to give with this slide is that don't assume you're not eligible. Again, if you test positive and you're having mild to moderate symptoms, just reach out to your healthcare provider and they can discuss with you like what treatments specifically you might be eligible for. And also, I just wanted to note that age is the strongest risk factor for severe COVID-19. I don't want to spend too much time on this slide, but basically this study looked at COVID-19 risk ratio for select age groups and comorbid conditions. And what they found is that the older you are, so the higher age groups had the higher risk of severe COVID-19, more so than chronic conditions like chronic kidney disease or diabetes with complications. So age really is an important factor in determining if someone is eligible. I also just wanted to take a moment to talk about what our program does at the health department. So aside from sending these important treatments to hospitals and pharmacies around the state, we also respond to congregate care settings where there might be someone with COVID-19 who needs these drugs. And of course, we know that people in congregate care settings are at higher risk for developing severe COVID-19. So if someone is in a correctional facility or a long-term care facility, the medical director is able to send us a request for treatment, and we are able to send it to them usually the same day or early the next day. And so just wanted to go back to this again of how do you choose the most appropriate treatment? Because I'm going to go into a bit of detail on, the three most common drugs that are used. And I wanted to reiterate that the provider will determine the drug that is most clinically appropriate. So I'll go through some of the details here, but don't feel like you need to memorize this. Just make sure that you have access to a healthcare provider, and we'll talk about this later, but what to do if the patient doesn't have a healthcare provider. Um, the best way for them to access a provider who could write them a prescription is by calling 211 um, to connect them with a free health clinic around the state or a federally qualified health center in FQHC. So I'll start with Paxlovid, which is probably the most commonly used treatment right now. It is an oral antiviral, and at the time of the clinical trial when this was released, it has been shown to reduce hospitalizations and deaths by 88% when taken within 5 days of symptom onset. And this drug is for adults and pediatric patients at least 12 years of age who are at high risk for progressing to severe COVID-19. It is an oral medication. It's taken for 5 days, and it's available at most pharmacies in Vermont right now. It does have moderate to high drug interactions, so this is really important to, talk with your provider. If you're on other medications, um, they have a checklist they can look at to determine, maybe you don't take your normal drugs for 5 days while you're on this, or there are ways to accommodate that. It shouldn't be a barrier just because there are moderate to high drug interactions, but there's a lot of resources right now for how to manage that if Paxlovid is indicated for a patient. And it comes in these packs, looks like this, in a box, and they're taken for 5 days. So I'm going in order of, treatments that are the most effective. So Paxlovid is, technically the most effective at 88%. Remdesivir has been shown to reduce hospitalizations and deaths by 87%. It's for adults and pediatric patients 28 days and older, so much younger group, who are either hospitalized or not hospitalized and have mild to moderate COVID-19 symptoms and are at risk for progression to severe COVID-19. It's given as an IV infusion. I believe it takes about an hour, and it has to be given 3 consecutive days in a row. This is the one drug that is not administered by the state and by the federal government, and so hospitals, or health clinics go through their normal method of procuring it, and there is a cost associated with it, and this would vary based on the patient's insurance. And it's available at select hospitals in Vermont. So it's not necessarily important to know which hospitals, but your provider will, there's kind of a map that the provider can see to see what is the closest location for you if you're the one who needs it, and they would just make sure that it's the closest location to where you're at. And the last one I wanted to share was bebtelovimab, which it was not part of a clinical trial, but it has been shown to improve symptoms and reduce the viral load, or so the amount of COVID-19 in your body on day 5 versus not having COVID-19. It's available for adult and pediatric patients 12 years and older, again at high risk for progressing to severe COVID-19, and for whom alternative COVID-19 options approved or authorized are not accessible or clinically appropriate. So maybe someone has an allergic reaction to something in Paxlovid, or they have a pretty severe drug interaction, then this drug might be a better fit. Again, the provider will determine that, but this is given as a one-time IV injection. So it's basically a shot, just about 30 seconds. It's available at select hospitals in Vermont. But one thing to note here, the supply of all of our drugs is really great right now, except for this one. So we have heard that this is because of federal funding going down, but by July, there will not be as much bebtelovimab available. So we're kind of reserving what we have for people who really can't take Paxlovid. But this is the one that's probably going to be less accessible in the next few months. And then the other two that are less commonly used, the molnupiravir is an oral antiviral, and this one is less commonly used because it's just not as effective. It's been shown to reduce hospitalizations and deaths by 30%. And it has some, negative interactions if people are pregnant. So if people are eligible for this, they need to do a pregnancy test. It's not recommended for use during pregnancy. And Evusheld, like I mentioned, is a preventative medication. So this is for people who are severely immunocompromised or who can't receive a vaccine. It's kind of like a vaccine. It's a preventative medication. So before someone gets COVID-19, and it's given through two shots, basically, in a hospital setting. And people who have taken Evusheld, according to the clinical trials, has led to a 77% reduction in developing symptomatic COVID-19. So again, how does someone obtain these therapeutics? If you test positive and you're at high risk for severe COVID-19, or you think you might be, just contact your provider and they will be the ones to, look at your health history and determine which treatment is best for you. And again, if you don't have a provider, please call 211 or consult the list of nearby federally qualified health centers or free health clinics. These treatments cannot be prescribed by a pharmacist. They have to be prescribed by a, a doctor or a physician's assistant, but unfortunately they haven't gotten to the point yet where you can just show your test to a pharmacist and they can write it. It has to be done by a provider. The main message again is test early and treat early. Don't delay in seeking treatment, even if you're vaccinated, even if your symptoms are really mild. Symptoms can change really fast and you could get sicker very quick. So by getting treatment, you could have less serious symptoms and may lower the chance of your illness getting worse and needing care in the hospital. So in these next few slides, I just wanted to show you where to find more information about this. If someone comes to you with questions and you wanted to find information on our website. So if you are just offering information to the general public, the best way is to, from our homepage, go to COVID-19 in the upper left corner, and then scroll down to symptoms and sickness. And once you're on this page, on the lower right corner, there's a box that says treatment for COVID-19, and you can go ahead and click on that. And this has, a video describing treatment options in different languages. It covers again who should get COVID-19 treatment. And it basically explains what I did in those earlier slides about the difference between antiviral treatments and the monoclonal antibody treatments. And it has some additional resources here on the bottom. It's possible that you might get questions from a nurse or a doctor, and this might be new for them. It shouldn't be totally new because they've been out for a while, but we do have some great information for healthcare professionals. If you, from our main website, go to COVID-19 again on the left side, and then go down to healthcare professionals. In this box here on the left side is healthcare professional guidance. And then once you're there, scroll down to COVID-19 therapeutics. So here's the healthcare professional guidance, and then there's a bunch of drop-down menus here, and the first one is COVID-19 therapeutics. This has information for healthcare providers about what options are available, how to order them, which is pretty crucial, and then it has information for residents of long-term care facilities, like I mentioned. So if they work with a skilled nursing facility or an assisted living facility and they're interested in obtaining therapeutics, there's a direct link to our request form right here. And there's also some great resources on the bottom if they have questions about what options are available. And I will just point out too that we work with a team of clinical advisors, which are mostly emergency department physicians from around the state. So if a healthcare professional has clinical questions about I'm considering giving this treatment versus this treatment, and they have questions, you can always have them email us. I'm going to show my email here at the end, and we can connect them with that team of clinical advisors to consult or advise on a case. I do receive questions, every once in a while about, how many do we have in the state? A couple months ago, we, had a shortage on some. And I just wanted to show people that at this point, we have really great supply, um, of monoclonals and antivirals in the state. The only one, and this is just a snapshot across the state of what was available probably when I did this last Friday. So lots of Paxlovid available. Renal Paxlovid is Paxlovid, but it's in a special box for people who have need a special adjusted dose based on their renal data. So bebtelovimab is the only one that's probably going to be in shorter supply in the next month or so because of that loss of federal funding. But as far as the other ones go, there's really great supply across the state. And if folks have questions about a certain area where they can't find it, definitely let our team know. And we can do some research. We're always onboarding new pharmacies to carry it. And then if it's a chain pharmacy like Walgreens or CVS, they should all have it. But if you're noticing that one location seems to be pretty low, we can always reach out to them too. So as a final takeaway message, if you test positive, contact your provider to see if you're eligible for treatment. Here's a list of resources. Some of these are, more helpful for healthcare professionals, like the Therapeutics Decision Aid to help providers decide which treatment to give. And we also have a link to the Health and Human Services page with announcements about new therapeutics that are coming out, or maybe old ones that are shown to be no longer effective. But we will always communicate that information on our website too. And that's the end of the presentation. Our team email is right here, this AHS one, and we check that, almost every day of the week. So feel free to send us an email if you have specific questions. And it looks like we have 25 minutes left for questions. So I'm happy to take any questions from the group.
Thanks, Lucy. So we have some questions from the chat. We had 2 questions pre-submitted that I think you've answered. One was about supply, which you just answered, and the other is about maybe you can summarize again. So our second question pre-submitted was, little is known about accessing treatments. What is the best way now? And will there be some marketing about this? So I know you've answered that, but maybe a summary again.
Sure. So the best way to determine like what treatments are available in your area is by contacting your healthcare provider. And it's really on the healthcare provider to find the closest, course or dose to you. Paxlovid, like I showed you, is pretty widespread. If it's something that's a little more rare, like Evusheld, your provider will look at this locator tool and find the closest dose to you. But as I mentioned, they should be available across the state, except for bebtelovimab.
Thanks, Lucy. So there are about 6 questions from the chat. And then if there are more questions, please raise your hand and we'll open up the floor. But I just want to give a chance to respond to things that were in the chat. So the first question is, how effective have therapeutics been in reducing chances of getting long COVID? Is there any data on this? I read in the news people with mild to moderate COVID symptoms are more likely to develop long COVID.
That's a really great question. And unfortunately, I don't have the answer to it, but I'm going to write it down to see if I can do some follow-up on it. Because these are authorized under an emergency use authorization, um, I'm not sure if any clinical trials are going on to really track that. I've heard that there are, but they haven't been peer reviewed yet. But I meet with a group of other states who distribute them, and I can ask this question to them because I think that's a really great question. I know they have been effective in preventing hospitalizations and death, but whether or not they're preventing long COVID, I'm not sure, and that's a really great question.
Thanks, Lucy. And we'll be sending out this recording and we can try to also put information about unanswered questions or things we need to look up with that recording email. So the next question from the chat is, who is the target audience for antivirals for folks with mild or moderate illness? Is there anyone, or specifically, is it for people with other health complications or risk factors?
So for the oral antivirals, that would be Paxlovid and molnupiravir, and they have the same language as the monoclonal antibodies. So they are for anyone who is at risk of developing severe COVID-19, and that was the link to the people with certain medical conditions. That's how the CDC is defining people at higher risk. So I can jump back to that. In terms of who is eligible. So consult this link. And as I mentioned, it's very broad. So don't assume that you're not eligible for it. If someone is over 65 or if they might have a disability of some kind or they don't exercise frequently, those are all connected with having a higher risk of COVID-19. So they might be eligible.
Thanks, Lucy. So our next question is actually about your comorbidities data slide. It's a question. So for the comorbidities data, is this true even when disaggregated by race or other social identity groups, for example, LGBTQ+, folks that are homeless? And there's a follow-up question. If so, is there data that is specific to these communities? Because that would be very helpful information.
Yeah, that's a great question. I wish we had that information. I don't think it was stratified that way. But what we do know is that people of color and people of certain ethnic groups have developed severe COVID-19 at lower ages, or when people are younger, maybe less than age 65. So I know that some states are looking at their specific state data on who is dying from COVID-19 and who is hospitalized to make some of these decisions. So for example, Maine, they have an older population and they have looked at this in their population and said that anyone 40 years or older should be eligible for treatment based on who is hospitalized and dying in their state. So that's something Vermont hasn't looked at yet, but I do plan to follow up with the EPI team on that. But as I stated before, well, I'm not sure actually we've reviewed this. In the people with certain medical conditions page, it does acknowledge that, people from certain racial and ethnic minority groups are dying from COVID-19 at younger ages. People with disabilities are more likely. So I guess the main message again is talk to your provider to see if you're eligible. I really wish we had that data, but I think this is pretty inclusive if someone is wanting the treatment.
Tony or Richie, I see your hands, and I know you both asked the same question,
Yeah,
so
I know
feel
I
free.
asked the question. I just want to be a little bit more specific too about like kind of what I'd be looking for. So I came to work for the Upper Valley Public Health Council, and I worked for Denver City Council, and I was a PIO for Boulder County during COVID 2020, and we developed a lot of data like this. And of course, it's a little bit more diverse out there. So looking at the impacts on specific communities is kind of something we did focus on. And I understand Vermont, may not have as much resources as Colorado, of course. But I will emphasize the importance of that data and how helpful data is to providing resources for marginalized communities, obtaining grants for marginalized communities, as well as noting too that the LGBTQ community specifically, a lot of people in the LGBTQ community and outside the LGBTQ community have a significant higher risk of immunocompromised disorders. Um, and that can affect how COVID affects them. And I think that that's something that I saw that was missing from this, is just highlighting that those who have AIDS and HIV and other immunocompromised disorders that are marginalized have a significant risk, a higher risk, and treatment options for them would be helpful, just because people already struggle to get treatment options for those conditions already.
Yeah, thanks for sharing that, Tony. Rebecca, you might be able to speak to this, but I know we do have data on certain populations and who is getting COVID, but we could definitely do a deeper dive, and that would really help with messaging too. So that's a great thought.
Yeah, no problem. I just know that it does help, like with local organizations, if they're doing like an initiative to provide these resources for those specific marginalized communities, so that we make sure our work is equitable.
Thanks. We can definitely take some notes on this, and I have been, and pass it on too. So everyone on this call really doesn't do any of our data analysis, but we'll pass on the request and see what is possible without having the data team here. Definitely harder to answer, but really, really appreciate this. And Richie, I want to also offer you the floor.
Yeah, thanks, Rebecca, and thanks, y'all, for putting this together. And Tony, for your insight. So just a little background on me, so folks have a little context. So I was the lead coordinator for the Southern BIPOC vaccine clinics. I've also been a data engineer in local hospitals, and I'm part of a greater national working group of data equity through LA Tech for Good. And one of the things that's super, super, super important that we need to do on every single time we have a slide on data is be explicit in that same slide, whether this is general population and if this has been disaggregated, because I can tell you with like a 95.73% probability. No, I'm just but a really high probability that these are definitely going to change once we look at these different social identity groups, and we need to also like start the and that helps keep the conversation going of like collecting race and ethnicity, and not just that, but connecting the social identity data, because the as a reminder, right, we didn't collect race and ethnicity in Vermont until like people pushed really hard for months and months and months, and of course, oh, look what we saw, the thing that all the people of color already knew but no one would listen to, right? we need to learn that lesson, and we need to make sure that we are always prioritizing on every slide talking about the general population, whether this has been disaggregated and analyzed by social identity groups, and just making sure that we keep that conversation going. Thank you.
Thank you so much. It's really important feedback for us. Tony, I still see your hand's up. I'm not sure if you had more to add or if we can move on. Oh, perfect.
No, you're you're fine. I think I accidentally clicked that.
No problem. So we'll try to speed through a few more. And again, please raise your hand or type in the chat if there are more questions. And also those we don't get to, we can try to respond to in our follow-up email. So the next one is VDH has fantastic graphics in the past during the pandemic. Are there digestible versions of these treatment message that are already available to share with our client? And I also know that we might have some comms representation on this call, so I encourage comms and Lucy if you need to address this question together.
Yeah, I'm just going to go back to the treatment for COVID-19 page and see. I think we have done some tweets and social media posts in the past, but it would be nice to post that so that partners could share that information. Just, test early, treat early. Does anyone from comms know the answer to that?
This is Ruth from comms. I will definitely pass that along. I'm not part of the social media team, but I do work with organizations to craft targeted messages. And so this is something that I can get into as well.
Thanks, Ruth.
Awesome. Thank you both. Really important feedback. So the next question is, does the Department of Health have a plan for if or when the federal money dries up? And this question I'm not sure if it's specific to just treatment. And I also know we have some other departmental staff. Monica, if you're still here, you may also have maybe some insight on this as well.
Yeah, so a few thoughts. One is, the normal method for getting medication is that the state and federal government is not involved. Like if a hospital needs a medication, they just order it from the manufacturer. And eventually, as these drugs receive federal or receive FDA approval, they will go through that process too. It's possible that public health insurance like Medicaid and Medicare might cover that. And so would other private health insurance companies. We don't really know at this point. It's really amazing that they're offered for free right now. But it really just depends on what type of drug too. So the bebtelovimab that's going away, that was directly related to a funding issue, but we have all these other options right now. And it's possible that the next variant might make some of our existing medications, not able to work against COVID, I'm blanking on the word here, ineffective against the new variant. So it changes all the time, but I think the goal, what we've heard from the federal government is that we will move to a place where they're ordered normally, and then it would be up to insurance companies to decide whether or not they would cover it.
Thanks, Lucy. So the next question is somewhat related. Is there any info on Medicaid coverage for, and excuse me, I don't know how to say the names of these, remdesivir?
Yeah, remdesivir. That's a good question. It's that one that's a little wonky because it's not allocated through the state and federal government, but that should be really easy to look up. So I can look that up and we'll send it out with the notes.
Awesome. Thank you all so much for these questions. We have one more related to treatment, one more on testing. So it was mentioned that medical directors for LTC can request treatment, but we do not have a medical director in our assisted living. Can it be through our DON?
Yes, absolutely. It's really anyone who plays a role similar to a medical director who kind of has a handle on the cases going on. And the main point is that everyone should be screened for treatment and their provider should order it. So you don't need to send us, the order from your doctor, but just let us know through this form that 5 people have been screened. It's a very basic form, and we're requesting 5 courses of Paxlovid, and we'll follow up with you if we have questions.
And then Anna, one testing related question came through the chat, which is, are there any updated info on supplies of tests? Will free tests be distributed again? And I know, so next week, the theme of this conversation will be on testing, so we'll have much more information then.
Yeah, thanks, Joe, for the question. I'm looking forward to our testing information session to dive into that more deeply. But yes, as folks on the call know, our state-sponsored public testing sites are closing at June 25th. And so after that, free at-home test kits will still be available through programs like the federal mailing program, which is currently in round 3. I can post that link in the chat. And then also widely available at pharmacies and through commercial retail. Insurance companies, including Medicare and Medicaid, are all required to provide coverage for 8 at-home test kits per member per month. So we're encouraging folks to be accessing their at-home test kits there, and at-home test kits are meeting a lot of the testing needs right now. And as Lucy alluded to in how that relates to treatment, you can have that positive test result on either a rapid test or a PCR test. So that would allow you to access COVID treatment.
Thanks, Anna. I don't know if there are any other questions. Feel free to raise a hand or pop them in the chat while we wait to see. So next week at the same time, Tuesday at 9:30, we'll do an hour on testing and testing program in Vermont. And then the week after will be around vaccine, around booster shots, vaccines for under 5. So we hope this has been helpful. Please feel free to send us feedback if you had any access or accessibility issues or needs to make this a more tech or accessibility friendly experience. And of course, please feel free to send us questions in advance of the testing and vaccine sessions, and we will send out the recording, the slides, additional links, and any questions we couldn't answer. We'll send that information out in an email as soon as we can. And thank you so much to Lucy too.